The topic of this discussion today will be on the etiology of both acute and chronic groin pain in patients who've had an open, laparoscopic, or robotic inguinal hernia with mesh. The first thing to recognize is that there are two types of pain. There's both acute and chronic or delayed pain. Acute pain is pain that you get in the immediate postoperative period and is usually limited to 3 to 5 or 7 days. Delayed or chronic pain is pain that may occur a number of weeks, months, or even years after the surgical intervention and can last months to even years. There are specific reasons for this type of pain. For the acute pain, there are two types of issues. The first is incisional pain. You're having surgery, there are incisions made, the surgeon will have given you local anesthesia, and when you wake up, there may be some incisional pain. This is easily handled by the use of ice packs to the wound or pain medication. It is usually self-limiting and will usually disappear in anywhere from 3 to 7 days, depending on how mobile you are. The more mobile you are, the quicker the pain will disappear. The second cause of acute pain is nerve injury. When you're operating on these patients, whether it be open or minimally invasive, such as robotic or laparoscopic, there are nerves in the area that may be inadvertently injured. The three nerves of interest are the ilioinguinal nerve, the genital branch of the genitofemoral nerve, and the iliohypogastric nerve. These nerves predominantly innervate the upper thigh on the surface, the inner thigh, the groin area, or the labia or hemiscrotum. These can be injured even by a surgeon who knows what he's doing. If a patient's having open inguinal hernia repair, the nerves are in the way and need to be gently retracted out of the field. If this happens, however, there can be inadvertent nerve injury, and this can manifest itself in the postoperative period. If you're doing the case robotically or laparoscopically, the nerves are usually out of the operative field, but they can also be injured. What happens when the patient wakes up and has this pain? If a patient wakes up in the recovery room with excruciating pain radiating along the nerve distribution, you have to assume that there either was an inadvertent injury to that nerve or that the nerve was manipulated. If you're doing an open case and you're positive that you've done the procedure correctly and the nerve was gently manipulated out of the field but still having pain, there's nothing to be done. If you're not sure and you've done an open case, then you need to re-explore the patient in the immediate postoperative period because the nerve is probably entrapped by a suture. If you're doing the case laparoscopically or even robotically, the biggest difference is in the laparoscopy, the sutures are not placed and they use tacks or staples to fix the mesh, while in the robotic case, they're sewn in. But either case, nerves can be injured. If a patient's had a robotic or laparoscopic mesh repair and the patient wakes up with this ridiculous pain, my feeling is that the patient should be immediately reoperated on and the tacks should be removed. Hopefully this will relieve the problem. Usually this problem will get better on its own, but it can take up to 3 months. If obviously the nerve has been transected, then that's an entirely different situation. The second issue is chronic or long-term pain or delayed pain. This can be neurological in origin also. So in other words, a patient is having surgery and what happens is the healing process involves scarring and the scars contract. And when they contract, they shorten and they can cause pain. They can entrap a nerve so that as the scar tissue contracts, it's around the nerve, starts to pinch the nerve. It's the same thing as inadvertently pushing it or grabbing it with an instrument. It can also, the scar tissue can be involved with the mesh, which is normal, and that can entrap a nerve. So you can have nerve entrapment that usually won't occur for at least 3, 4, 5, or 6 weeks postoperatively. And there are very specific ways to prevent that. That is one type of chronic or delayed pain. The second type of chronic or delayed pain is pain that's secondary to the mesh, and we'll have that discussion in a little while. So how do you prevent the acute pain? Obviously, you're careful that you don't injure anything and that you don't staple in the wrong spot. How do you prevent the chronic pain? It is very important that these patients' scar does not contract acutely and that you keep it stretched, because the repair is not based on the scar tissue maturation, but rather on the mesh itself. So what I do in my practice is the patients are told the night of surgery they get on a treadmill at a fast walk, 2.8 to 3.2 for 20 minutes. 3 times the next day, 3 times the day after, with as much mobilization as they can, with their only restriction is that they can't drive a car or lift more than 15 pounds. On the third postoperative day, they have full unrestricted activity. That means they can play ball, they can take a jog, they can play golf, they can do any lifting that they want. There is no restriction. The more they do early, the quicker their pain will go away, and the less likely that the scar will contract, causing nerve entrapment. I bring them back to the office within a week to make sure that they're doing what I told them to, and if not, I extend to them and show them how to do hyperextension exercises. And what's interesting is that patients can come in with discomfort. We spend 5 minutes doing hyperextension exercises, and dramatically they're walking better and doing better. So that's the way that you really can prevent this chronic, long-term nerve entrapment pain. Sometimes it doesn't work. Sometimes the nerve is so entrapped that it becomes an issue. In that case, depending on where it's entrapped and the location, it can be handled by the use of injections sometimes, oral medications, or pain management. However, that doesn't always work, and sometimes it will require surgical intervention. The other type of discomfort that we're talking about, long-term or chronic, is mesh-related. Depending on the patient's habitus, the mesh used, how the mesh is fixed, where the mesh is placed, may determine whether or not a patient has mesh pain. Interesting enough, mesh pain usually doesn't occur for a number of months, sometimes not even for a number of years. I've seen patients that have had hernia operations open with mesh and 9 and 10 years later come in with now chronic groin pain. It's a very difficult problem in these patients. Very often we'll examine them to make sure they don't have a recurrence. If they do, then that's probably the etiology of the pain. If they don't have a recurrence, then I'll do an MRI to rule out a recurrence that I can't clinically feel or whether or not there's something else going on. These patients then require very specific care. We try local injections, we try oral medication in an attempt to relieve the discomfort. However, occasionally the discomfort cannot be relieved. And if we try hyperextension, anti-inflammatories, pain management, pain medication, and local anti-inflammatory, and the pain is not better, and it's significant, and it's causing dramatic change in the patient's lifestyle, then we have to consider explantation. Explantation of the mesh can be very difficult. Remember, this mesh is incorporated into body tissues with scar. It's stuck to nerves, arteries, and veins. It sometimes requires both an open and a minimally invasive or laparoscopic approach to make sure we don't injure something. Once we've taken the mesh out, we have to reconstruct the groin. It can be done with another piece of mesh. Many patients don't want to. If we don't, then we have to repair it without the use of mesh, and the recurrence rate is significantly higher. So the best way to prevent these problems and the best way to prevent chronic groin pain is to first make sure that you don't injure any nerves at the time of surgical intervention, that you keep the patients active very, very early, that you get them to do hyperextension activity, full range of motion, and full activity levels very, very early. Third is you make sure that you use the proper mesh and it's placed in the proper location for that specific patient. There are different techniques used. All are acceptable, but some are better in certain types of patients than others. That is the only and the best way of preventing long-term chronic problems. If you develop a chronic problem with chronic pain, it can often be made better with surgical procedures, but they should not be taken lightly and they should be used as a last resort.